Next, we have Dr. Anthony Khoueiry, and he is an associate professor of clinical medicine at the Keck School of Medicine of USC and director of the hepatobiliary cancers research and phase 1 program at USC Norris Comprehensive Cancer Center. He completed his medical degree and residency in internal medicine and fellowship in hematology and oncology at USC. Dr. Khoueiry.
Thank you for the Cholangiocarcinoma Foundation and the meeting co-chairs for the invitation to present. So this is an interesting topic because really not much has changed since the excellent presentation given last year by Jennifer, I think, on this topic of adjuvant therapy. So I will kind of summarize where we stand, but really spend some time talking about how do we go in what ways we go in the future. So Julie set me up very nicely for this discussion. So surgery does remain the cornerstone of any potentially curative therapy for biliary tract cancers. The 5-year survival rates are quite variable depending on what series you look at and which disease subset you look at, but they're generally poor. And it's an estimated 35% of patients who are able to have resectable disease at presentation and have high relapse rates. Hence the need for an adjuvant therapy to enhance the chance of cure. Some of the things I'd ask you to keep in mind as we go through this discussion is that until recently, the data on adjuvant therapy has been limited to retrospective series and single-arm trials. There is heterogeneity of the primary disease sites, as we heard, hilar, intrahepatic, extrahepatic gallbladder, with variable recurrence patterns. There is heterogeneity of the molecular makeup based on the primary site, and we have not looked at that in regards to prognosis very well. There are variable recurrence patterns, as I mentioned, and the resection margins play a unique role in this disease, especially in the hilar cholangiocarcinoma subset. So this is one example where the patterns of recurrence are obviously much higher in the locoregional setting for hilar cholangiocarcinoma versus a higher chance of systemic recurrence for gallbladder cancer, for example. So let's start with data from prospective trials of adjuvant therapy. So this is the BCAT study, which is a randomized trial of adjuvant gemcitabine versus observation resected bile duct cancer. This study actually did not accrue the full planned 300 patients. It closed a bit earlier, and it was negative. Basically, there was no improvement in overall survival or relapse-free survival in this study. And I'm going to come back and visit some details on these. Next is the PRODIGE 12 Accord 18 study in France, which took all biliary tract cancers, including intrahepatic, and those patients were randomized 1-to-1 to gemcitabine oxaliplatin versus surveillance. And again, this study, even though there was numerically an improvement in relapse-free survival, it was negative statistically, as you can see here. And you see that the median overall survival also was negative, no significant improvement. Then came BILCAP with the UK team, and thanks to Juan Valle and John Bridgewater for sharing these slides. I'll spend most time on this trial since it has changed the standard of care, and then go from there. So this was a 2-arm open-label randomized controlled trial, post-resection randomization to capecitabine, 8 cycles, 8 3-week cycles versus observation, primary endpoint of overall survival. And you see here, and this is an important point when we look at the size of these trials, that this study had to undergo a couple of revisions based on changes in outcomes of patients with best supportive care over time. So the power and the recruitment of the patients was increased, and the number of events required you see on the right-hand side. So these were the baseline characteristics. You see that the accrual spanned all subtypes of disease, with including intrahepatic, hilar, gallbladder, and distal. 38% R1, ECOG1 was 52%, and 46% of the patients had N1 disease. Here you see the overall survival by intent to treat analysis, 51 months versus 36.4 months. Unfortunately, this did not meet statistical significance. However, based on a pre-planned sensitivity analysis that adjusted for established prognostic factors, such as nodal status, disease grade, and gender, the hazard ratio was 0.7 with a significant p-value, so 30% reduction in the risk of death with capecitabine. This is the analysis by the per protocol population. It's only a difference really of 13 patients, but these were the patients who completed the therapy as per protocol. And again, here you see a significant improvement in overall survival in this population. Similarly, an improvement in relapse-free survival, 26 months versus 18 months with observation. On subgroup analysis, you see that all the subgroup analyses favored capecitabine, as listed here. Won't spend much time on this, except to point the R1 subgroup, which I'll come back to, where you see that maybe these patients did not seem to benefit as much. And here are some more details. And again, thank you, John, for sharing this slide. These are the R1 patients, and broken down by site of origin. And you see that the majority of them were hilar or extrahepatic cholangiocarcinomas where there was an R1 resection, which is, and R1 resections are less common for intrahepatic and gallbladder. And here you see at the bottom two lines that the patients with R1 resection, whether they received capecitabine or observation, there was not much difference in these curves. They pretty much overlap, whereas there was a more significant separation for the R0 subsets. So this leads me to SWOG 0809, which was a single-arm study, a phase 2 study that focused only on gallbladder and extrahepatic cholangiocarcinomas, including hilars. The eligibility were T2 or above and node positive or positive margins. Patients received GEM-CAPE, followed by concurrent CAPE and radiation. And you see the baseline characteristics of these patients. 65% were bile duct patients and 35% gallbladder. You see the breakdown, but the majority were stage 3A or above, and I'll come back to this a bit later. But this trial met the endpoint of improvement in 2-year overall survival. It was 2-year estimate of overall survival of 65%. The median overall survival was 35 months with this approach. And interestingly enough, there was no difference in outcome between the R0 and R1 subgroups in overall survival or relapse-free survival, which raises the question, was radiation the equalizer in this situation for the R1 subset of patients? So I put these trials in a table. This was actually a table that Jennifer developed originally, and I modified it and added a few things. But I highlighted a few things. The number of patients recruited to these trials are quite variables. And why were 2 studies negative, and why was BILCAP positive? And one could hypothesize about this all day, but nonetheless, the power estimates are very important and the statistics. So we need to accrue enough patients given the variability and heterogeneity of this disease. The breakdown of the subsets recruited to the different trials does matter. You see that PRO-DISH-12 had a large subset of patients with intrahepatic cholangiocarcinoma. The subset of R1 disease may matter. How many patients were node positive, high variability. You see with BCAT that 44% of patients were T1 and T2, lower risk patients. And on and on. Then I added some comments below to make us think also about toxicity. In PRO-DISH-12, 72% had grade 3 or 4 toxicity, and only 33% of patients completed 12 cycles of gemcitabine and oxaliplatin. In BCAT, 52% of patients completed protocol therapy, and of course, it didn't accrue to the maximum planned 300. So all these things need to be taken into account as we interpret this data. What about large meta-analyses and large series? They're still relevant, I believe, in this disease to help us move forward. This is one analysis done by Jennifer Knox's team at Princess Margaret, where they looked at 20 studies. And without spending too much time on this, if you go and see to the results, when looking at all patients who received adjuvant therapy, there was no statistically significant improvement in hazard ratio for all comers. However, when the analysis was focused on node-positive patients or R1 resection patients, there was a significant improvement in hazard ratio with the addition of adjuvant therapy. Adjuvant therapy here included chemotherapy or chemoradiotherapy or radiation therapy alone. But generally, the meta-analysis also found that chemo or chemo-RT was superior to RT alone. So again, this is the subgroup of node-positive from the meta-analysis where there is a significant benefit, and subgroup of R1 resected patients where there is a significant benefit. This is another meta-analysis that's more recent, looking at 30 studies, but only that patients who got chemotherapy. This is not chemoradiation or RT alone. Again, similar message where overall there was actually a benefit from adjuvant chemotherapy in this study, and this was all disease sites included. But again, when you look at the study more carefully, the significant benefit was mostly in the patients who had node-positive disease or high T stage, T3 and T4 disease. Looking at our specific subsets, meta-analysis for gallbladder cancer. This is from the US National Retrospective Cohort Study, and this is a multivariate analysis for various prognostic markers, but you see on top that adjuvant chemotherapy was associated with improved outcome in gallbladder cancer patients that were T2 or above or node positive. Similarly, this is looking at another meta-analysis looking only at intrahepatic cholangiocarcinoma. 1,150 patients, 30% received adjuvant chemotherapy, 52% were gemcitabine based, and you see that the 5-year OS for T2 and above tumors was 37 versus 30%, and there was a trend for improvement also for N1 positive patients. Here on Cox regression analysis, again, the strongest association was between adjuvant treatment and survival in T3, T4 tumors and N1 disease. For hilar cholangio, again, this is another series where there seems to be a benefit to adjuvant therapy, both in overall survival and relapse-free survival, but the association was not present when the node-positive patients were removed from the multivariate analysis. This is the only thing I'm going to show about RT alone, but again, the message here, if you focus on the right of the slide, that the main benefit from adjuvant radiation therapy was in R1 and R2. This was mostly R1 resected patients, where it was not statistically significant for the R0 patients. So where do we stand in 2019? Single agent capecitabine is a standard adjuvant treatment option for patients with resected biliary tract cancer. Challenges, this was only one study. The intent to treat analysis was negative, but nonetheless, it has established a new standard. It's the best we have currently. For hilar cholangiocarcinoma, where there is a higher risk of R1 resections, one can still consider chemoradiation as an option based on the results of the single-arm SWOG 0809 and other data that I've showed you. Again, the challenge 0809, it was a single-arm study. Other negative trials that I showed you are limited by a multitude of factors: inadequate power, toxicity and therapy completion, large variation in primary site of disease that was accrued, and maybe not enough high-risk patients in some of these trials. Pending results of ACTICA, which is randomizing patients to gemcitabine cisplatin versus capecitabine as the control arm. This trial was modified. And R1 patients are being randomized to radiation versus chemotherapy continuation. We're also awaiting the JCOG 1202 S1 versus observation adjuvantly. There's a potential North American trial that we are contemplating with GemCape versus capecitabine, again with an R1 randomization to radiation or chemo continuation. So moving forward with collaborations, I think we need to be conscious about enriching for higher risk patients, N+, T2 or above, R1, but we also should start moving beyond histologic and clinical risk features and look at other high-risk features molecularly. One size does not fit all, so specific trials may need to tackle different questions based on the primary site of disease, and I'll show you some examples. We should take patterns of recurrence into consideration because that guides the therapy also of choice. It's time to consider molecular subsets and their prognostic impact also in the earlier disease setting, and really start thinking more and more about neoadjuvant and perioperative considerations. So this is an example of a trial led by Shishir. Thanks for sharing the slide. where patients with incidental gallbladder cancer are actually, rather than being taken to surgery up front, which is the current standard, they're being randomized to surgery up front versus neoadjuvant GemCis, followed by surgery and followed by adjuvant capecitabine. Another trial that we heard about also is exploring GemCis, nab-paclitaxel, a triple combination with a high response rate, neoadjuvantly for high-risk intrahepatic cholangio, also led by Shishir. And this is something else to stimulate us. This is looking at tumor-infiltrating neutrophils and their association with outcome with adjuvant therapy benefit and prognosis. And without, again, spending too much time on this, so I can end on time, the bottom line, a higher frequency of tumor-infiltrating neutrophils in cholangiocarcinoma was associated with poorer outcome with adjuvant therapy. So can we select patients based on also molecular and maybe immune markers in the future rather than just clinical features? So thank you all for listening, and I think this meeting, again, as Jennifer said this morning, is inspirational. It reinvigorates all of us, so I hope we can move forward together. Thanks.
All right, thank you, Dr. Khoueiry. So